So that with that in mind, that's what we're going to talk about a little bit today. Is genomic markers and how we use somatic tumor markers to guide our patient care and where we're going in the future.
I think it's really it's kind of a quiet revolution going on, is the way I would put it, in prostate cancer. For really forever, we've thought about prostate cancer as one disease, as a disease that is essentially driven by the androgen receptor pathway, and that's it. And that has essentially been the biology of early, middle, and late prostate cancer, and how we think about the disease. And it's still there. I don't want to make it sound like that's gone away. But I think what we've begun to realize now is that there's really a tremendous amount of additional genetic variability in this disease. We knew it was there, we just didn't know what to do with it. And now with some of the characterizations that we have, we're beginning to see precision medicine emerge. And I think you're going to continue to see that. What's interesting about, kind of the genomic profiling is that is really two things. One is that, this is something that appears early in the disease. So we think about prostate cancer and the natural history of being, in some cases, 10 or 15 or even 20 years of disease progression over time. And yet the genetic alterations present in the prostatectomy or prostate biopsies really are the blueprint of what's going to emerge over time in that disease. In the majority of cases, there are truncal alterations that happen, but these, there are branch alterations that happen, but these truncal, alterations, these things that happen at the very base of the formation of this disease are really critical to, how that cancer is going to behave over time.
My second question would be, how do you counsel your patients about discussing these genetic variants that we find, these or genomic markers, in terms of how we tell them about what they should be doing in terms of their family? Should they be also getting tested for these?
I think some people sort of take this in sort of a little bit of a stepwise approach, and I think that's reasonable for early disease. There's a lot of patients with early localized prostate cancer that we could do active surveillance on, or we could do kind of a limited monotherapy, really definitive therapy, whether that's surgery or radiation. And for these patients, I feel pretty comfortable, we could do that kind of definitive treatment. And if they don't relapse, that may be all they need. Now, if they have a strong family history of prostate cancer, or say breast, ovarian, or pancreatic cancer, then I'm still going to want to profile those patients. And when I say profile, we're going to do germline and somatic profiling in those patients. But for patients who don't have a really, significant family history of cancer, those particular cancers, and have relatively organ confined, lower intermediate risk disease, I'm fine not profiling those patients until there's evidence of relapse or spread. But for the majority of patients I see as a medical oncologist, they're more either locally advanced or they're metastatic. And for these patients, David, these are the patients that we absolutely don't want to miss a genetic alteration. And we would like to know that early for precisely the reason you said, because it may have relevance to family members right then and there, in terms of screening, in terms of other malignancies, in terms of even management of people that have prostate cancer. I've diagnosed mutations in one patient, and they've gone and talked to their brother who's had prostate cancer longer than them, and checked, and they have mutations. And if I hadn't checked in the first patient, the second patient might not have ever known. So, I think those kinds of things are, it's still becoming kind of, systematic in our approach. Right now, it's still kind of individual, check this patient, at an individual time. And what I'm hoping we emerge to is more of a systematic approach, where we kind of routinely or reflexively test patients when they hit a certain point in the disease progression.
Sure. So in terms of, systematic checking, so I don't think you can remove cancer diagnosis, let's say specifically prostate cancer diagnosis and anxiety and cancer-related cancer-related patient worry. What are some resources that you give to your patients or have your patients set up with to deal with some of those things with let's say a germline testing that's positive?
Yes, yes. So this is a really important point that you bring up, and that's really kind of the patient anxiety around all of this testing and what does it mean and the implications. First thing, I think the greatest anxiety is not knowing. And even if you don't discuss it with your patient, they may find out, they may read about, they may be thinking about, is that relevant to me or not? So this isn't the kind of thing we can just ignore now. I think we do have to assume that all of these patients, have some access to information around this, and addressing it proactively with those patients. If it's somebody I'm not testing in, explaining why. If it's somebody I'm testing in, explaining why this information is going to help them. It's going to help them really understand, more about their cancer. And not knowing is really the worst case. And then when somebody comes back positive for a genetic alteration, and if that's somatic, I reassure them that it's somatic. It's not something that they inherited. It's not something that they're going to pass on. So that's another great peace of mind for people. And so being able to address that up front and put that into context is so key. And that's why I like to check both germline and somatic at the same time so that I can address both those issues with patients right away. And if it turns out to be something that is germline, that is something that could be related to the family members, again, I find this reassuring. I find this, I didn't cause this. They didn't cause this. The worst case scenario is not knowing it. So knowing it gives us the knowledge and the power to be able to educate all the other family members to see who, if any, have it, and if they do, which ones, and to be able to then proactively use that information to screen or even prophylax patients accordingly. So knowledge is power, and I try to explain that to patients and give them the comfort to say, we're going to walk you through all of this. Now, I'm lucky at a place like Duke where we have genetic counselors, we have molecular tumor boards, we have resources of experts around me that I can easily tap into. But those resources are available out there as well in other communities. It may take a referral to an academic medical center if you don't have that in your own practice, but it's well worth it to do that for these patients. They'll be grateful to you and loyal to you for doing that and recognize that you are the one to diagnose and really help manage this problem, not just for them, but for their loved ones.